From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. Aleksander Krag, Professor of Hepatology at the University of Southern Denmark in Odense, Denmark. Today we will be discussing a JAMA article that he co-authored titled Alcohol-Related Liver Disease, a Review. This article was published online in JAMA on July 6th, and there is a link to the article in the episode description. Dr. Krag, thank you so much for joining us on this podcast.
It's a pleasure.
So your article discusses that alcohol-related liver disease, which we will call ALD in this podcast, is the leading cause of liver-related morbidity and mortality and the most common indication for liver transplant in the U.S. and Europe. Can you describe the amount of long-term daily alcohol use that is typically associated with the development of ALD?
Yes, so actually we normally say that people, if it's a female drinking more than 20 grams a day, or a male of 30 or 1 or 2 units if you're male or female, we say that's where sort of the risk takes off. And then if you're male, it's more or less of a linear risk. But actually if you're female, it's a non-linear, so it rises steeply. And the issue is that it's difficult to find a lower limit. And of course, the higher you go, the higher risk is. But what's very important, and what we're also emphasizing in the review, is that alcohol should not be seen in isolation, because it interacts with cardiovascular risk factors. So actually, alcohol becomes more toxic, higher risk of liver disease if you also have type 2 diabetes in particular, and overweight.
And just to explain for grams per day, what is the equivalent in terms of standard drinks?
Yeah, so standard drinks across the world differ a little bit. So in the United States, it's 14 gram. In UK, it's 10. In Denmark, it's 12.
Can you discuss recent trends in the U.S. in terms of heavy drinking, which I think you defined as 5 or more drinks on any day, or 15 more drinks per week for men, or 4 or more drinks on any day, or 8 or more drinks per week for women?
Yeah, so we've seen actually in the United States that the prevalence of alcohol-related liver disease has risen. And what we saw particular a trend during COVID, where we saw a lot of increase in the United States and also in Europe. However, the rise in the United States seems to be more pronounced, where in Europe it's stable high. And that's associated with that this is the leading cause of liver disease. With in the United States, it's 43% of all adult liver transplantation. That's 3,500 a year that's done by ALD. And still the majority of these people, they never get to a transplant. And the pattern is the same in Europe.
So what is the spectrum of liver disease that ALD can cause?
We have on the one side very low alcohol consumption. We call that MASLD, metabolic dysfunction associated steatohepatitis or steatotic liver disease. Then we have an intermediary group with intermediary alcohol consumption called MED-ALD, metabolic dysfunction and alcohol-related liver disease. And then we have with the higher level, above 50 and 60 grams if you're male or female, that we call alcohol-related liver disease. But it's important to remember that across the entire spectrum, 98% have cardiometabolic risk factors. And actually more than 50% have 3 or more cardiometabolic risk factors. These are very intertwined with alcohol. And in many different ways, alcohol contains a lot of calories. Alcohol directly induces hypertension, dyslipidemia, and more advanced stage diseases, also type 2 diabetes. So that's the one scale where we understand the weight of alcohol versus cardiometabolic risk factors. And that's very important when we come to how we approach it clinically. The other layer is then the severity of liver disease, and where you can have initial liver disease against heavy alcohol consumption for a short period leads to steatosis, basically fat accumulation in the liver. Alcohol cannot in a big amount be broken down and metabolized completely, so it transforms into fat that's in the liver. And that can then lead to inflammation. That's back to the whole pathophysiology. And then what is the disease itself is fibrosis, basically scarring in the liver, change of the functional liver part into scarring. And the severity of the scarring, that is what actually we do stage people, how severe is the disease, and that is what is directly related to morbidity and mortality. And that's again the part of the liver disease where we can see early stages, the first stages, which will take decades to develop, is completely asymptomatic. And then you have the more advanced stages where people get the classical signs of liver disease, the decompensated, with ascites, hepatic encephalopathy, jaundice, maybe variceal bleeding, etc. The whole stage where people can be saved with liver transplant, but otherwise the outlook is not good.
And where does alcohol-associated hepatitis fit in there?
Alcohol-associated hepatitis is a little bit different because that can actually emerge at any stage of disease. Mostly it actually emerges with people that already have more advanced fibrosis and they're more sensitive and have higher mortality. But essentially any person with very high alcohol consumption can develop this. And this is a severe reaction to alcohol, even though it often happens when people have been having heavy drinking and then pause. And then they come to the hospital severely affected with severe jaundice and with high mortality.
And what are recent estimates of ALD in the general population and then among hazardous drinkers and those with alcohol use disorder?
Yeah, so these are estimates, and that's very important. And there's a lot of evidence that this is probably underestimated. And some meta-analysis suggests that the overall prevalence of ALD in the general population is 3.5%. And that then rises to 26% among hazardous drinkers, and probably even more, maybe more than 50% in people with alcohol use disorder. So these are clinical entities that are very important to look for.
And ALD progression is associated with higher quantity and longer duration of alcohol use. But what are some other risk factors for progression of ALD?
Yes, so duration, amount, and gender. Females are more sensitive. Then we have genetics. We have several risk genes. Some actually means a lot. We don't regularly assess genes. Then we have the cardiometabolic risk factors, as I said, and they are very important. They make a big difference. And the risk of developing liver disease in a lean versus obese or with or without diabetes is very different. Smoking is also independently associated with progression of liver disease. So these are some of the key risk factors we can actually approach and also discuss with our patients.
And in which patients should clinicians consider the diagnosis of ALD?
So again, on the one extreme, you have the jaundiced person, maybe alcohol-associated hepatitis. Ascites, most likely, or is a liver-based decompensated cirrhosis, most likely alcohol if you're United States or Europe. But then you have the whole spectrum of earlier stages, and that's basically where we want to go. If we really want to change something, we should actually get people at a much earlier stage. And that's where I think we need to have these triggers of when do we think liver disease? When do we consider does this patient might have a liver disease? And of course, harmful alcohol consumption. We just mentioned that this threshold of 20 or 30. But again, that can change over time. So I would say part of good clinical practice in primary care, but in any care, is actually to have the conversation about alcohol because it's a modifiable risk factor. But then also we measure liver function tests for a variety of reasons across any clinical setting. And that's also, let's say, a yellow flag. And then also if we do a lot of imaging for various reasons, CT, MR, ultrasonography, and if you have a steatotic liver, white liver, then you should also consider or have this conversation.
And can you describe the approach clinicians should take when assessing an individual's alcohol intake? And do you recommend the use of alcohol biomarkers?
Yeah, so you need to have this open conversation about the alcohol. So basically the open discussion is number one. Then we have the audit score, audit C score. It's about quantity and frequency. Basically different questions of how much you drink, how often you drink, and then you get a risk of alcohol use disorder. But also be open to that some people binge drink, this thing about more 4 or 5 at a time, and some drink more regularly. So that also means you need to ask back in time, how much did you drink a year ago, or when you had the different drug, or when you were traveling a lot or when you were going through your divorce. All these things have to be open. So that's sort of the getting into the patient, get the trust, and actually also be clear that this is a very stigmatizing thing to discuss, so that you're open, actually try to approach this of gaining the trust that you're here to help people, not to judge them. And then in recent years, there's been more emphasis and more research supporting objective biomarkers that are breakdown products of alcohol. I think these are the ones I think should be used. We have different liver function tests. It could be gamma glutamyl transferase, ALT, AST. They're very sensitive but not very specific markers. So they would change in many different situations. So that's why we actually recommend a biomarker like phosphatidylethanol, a breakdown product of alcohol that is embedded in the red blood cells cell membrane. So when you do a mass spec on that, it's a very specific but also very sensitive method, but only captures the last 3 to 4 weeks of alcohol. But that's a very important add-on to the conversation and actually stating how much does the patient drink. And again, it's not only just because the patient don't want to tell. It can be difficult, as we just said, with remembering, okay, how big is this glass? How strong is this alcohol actually? And what did I have last week or 2 weeks ago?
Great. And moving on to diagnosis, which first-line non-invasive testing is recommended to screen for ALD?
The index test we recommend for fibrosis is called FIB4, Fibrosis Index 4, and is made by ALT, AST, AIDS, and platelets. And it's actually good at say if this is low, below 1.3, there's low risk of liver disease. But if it's higher, you need to have a confirmatory test. And there you have a variety of tests. What we often used in liver clinics is transient elastography, a measure of the liver stiffness, which is actually very strongly associated with the severity of disease, but also with the prognosis. Then we have other tests like some circulating tests like ELF test, which can also be used and actually have similar properties. And that's sort of the test that confirms the severity of disease.
And in the current diagnostic algorithm, is there a role for liver biopsy in the diagnosis of ALD?
Yes and no. On the one end, if we have alcohol-associated hepatitis we discussed, severe jaundice, we can be in doubt, should this patient be treated with steroids? There's a controversy, is it good or is it bad? Then we would actually often do a liver biopsy in that extreme. Then on the other, you might have a patient where everything adds up. Okay, this patient may have elevated BMI, have a long history of significant alcohol consumption. You have a high FIB4, let's say it's 2.7. Then you have a transient elastography that says, okay, this is 12. And then it sort of adds up and you rule out all other kinds of diseases. We always do that because they could have concomitant hepatitis B or hepatitis C or alpha-1 antitrypsin deficient, what we would call the liver screen, what liver doctors would do, rule out other causes you can approach. Then you don't need a biopsy. So I'd say in clinical practice, in maybe 90%, but depending on your clinical setting, you would not need it. So you can establish diagnosis, you can target the patient and actually diagnose them without a liver biopsy. I think that's a key thing.
And the goal of treatment for ALD is alcohol abstinence. Can you describe some recommended behavioral therapy and medication-assisted therapy strategies?
Yes. So the thing, I think it's not just alcohol is the key. Of course, if you can reduce alcohol consumption, this is just the most strong one. But it's not shouldn't be seen in isolation. You need also to work on the cardiometabolic risk factors. So first you characterize, I said, do you have an alcohol use disorder or not? Because that's, I would say, is a specialized thing. So I'm a liver doctor. So if I have a severe addiction, I refer to addiction specialist or psychiatrist, because then you may need something more specific. But if you could learn then to use some of the simple treatments, we have this motivational interviewing or what's called brief intervention, which is again scientifically documented, and people can be trained in this. How do you actually have a conversation with the patient? How do you motivate people? And again, this can improve or actually achieve alcohol reduction or abstinence. And again, alcohol abstinence is, of course, the best, but any reduction in consumption at any stage of disease is actually beneficial. So that's important that you don't disincentivize the patients if they cannot achieve abstinence, but any reduction. And that's where, again, I think back to the biomarkers we can use, just like we have blood pressure, we have weight. How do we motivate people? Say, okay, you did great. your PET test there decreased from 800 to 400 or something just like you would say, okay, you lost X number of kilos, and this is related into a reduced liver stiffness, or some of these things where we have a conversation around that. And then there are the more advanced, which I think is for more specialized, to have people, okay, what kind of drugs can you use? We have camprosate, naltrexone, and we also have baclofen, which are used.
And your article mentions that ALD is currently the most common indication for liver transplant in the U.S. It's increased from 17% of total liver transplants in 2012 to 41% in 2023. Which patients with ALD should be considered for liver transplant? And is sustained abstinence from alcohol still mandated prior to liver transplant?
Yeah, this is a great question, because this is actually where I think that in my view, the field has moved in many, many places, but transplant is definitely when it's moved. And I think we're doing a great job in the United States, but also in Europe, that this is the leading indication for liver transplant. It's rising, but it's also, let's see, on the back curtain of actually the burden of hepatitis C is declining. That also tells that when you have effective treatment, you do something about it, the transplant rates go down. So we will say, in general, when people have a MELD score of more than 15 in Europe, in general, we consider transplant. You might go a little bit lower in the United States. And then we would say if you have decompensated disease, you should always consider transplant. And MELD score is then a score you use in the unit system to allocate on a fair way. So based on simple blood test, a calculated test that sort of predicts what is the 3-month mortality among these patients.
And then in terms of the alcohol abstinence, what has changed about that?
Yeah, historically, we would not transplant people who were not abstinent. The rule was that, okay, people need to document 6 months of abstinence. And then there was actually a French landmark study some years back that showed that these people could actually do pretty well, even with less than 6 months. There was a little bit more people who relapsed to alcohol, but the overall survival and the benefit of these patients were similar. And that has been taken up by a vast amount of centers and more centers in the United States and in Europe. So that's also, I think, a new and important message, that if people are at a stage where they will benefit from transplant, they should be assessed independent of their current alcohol consumption. And you should not necessarily wait these 6 months, because that might be exactly the window needed to save them, or they risk dying on the wait list.
And just a couple more questions. ALD prognosis depends on liver fibrosis stage and whether patients continue to consume alcohol. Can alcohol abstinence reverse liver injury in ALD?
A great question. And I think that's, again, an important message, that liver disease, in steatotic liver disease and alcohol-related disease, is to a very large extent reversible. So fibrosis can regenerate. It's an active tissue, actually. So even with cirrhosis or decompensated, of course, the more advanced you come, the more you come to decompensated, etc., the less reversible. But in general, it should be considered reversible. And that's also the message to the patient, that actually, if we target this, in particular alcohol consumption, then there's an opportunity to reversal or halting disease. And again, I think this, conjunction, don't forget the cardiometabolic risk factors, which basically is the component we will call MASH today, which is also a lead driver of liver disease. And then here we just have alcohol on top that just makes it altogether more aggressive. So yes, the bottom line, it is reversible, and all the earlier stages are completely reversible. Steatosis can disappear completely. Inflammation can also, and these happen quite quickly. But the other ones there, if we have these people who are treated or halt alcohol, we can see how all these different tests, they decline, and their liver prognosis become completely like the background population.
Very interesting. Before closing, is there anything we didn't discuss in this podcast that you'd like to mention?
I think we mentioned these important things. Look for it, treat it, and again, gain the confidence. And I think it's also important to know that now there are active clinical trials treating fibrosis in these patients.
Thank you so much for sharing your thoughts with us about this interesting and very important topic. I'm Dr. Kristin Walter. I've been speaking with Dr. Aleksander Krag, professor of hepatology at the University of Southern Denmark and Odense, Denmark. You can find a link to the JAMA Review article we discussed in this episode's description. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.